So I'm Sarah Vincent. I'm one of the stroke coordinators at Corvallis. I have another coworker, Dan Sherman. He's the other stroke coordinator in Corvallis. And then Jody Andrews is the Albany stroke coordinator. Please do know, I know it's early. If you guys need to get up and walk around so you don't fall asleep, I totally understand. I totally understand. Okay, so I am here to talk about stroke assessments, rapid recognition, and kind of why we're asking you to do a few things differently. And so we'll kind of go over all of that. Why do we care what we're doing? Unfortunately, stroke is like the number one disabling diagnosis out there. Once you have a stroke, if you don't hit that intervention window, unfortunately, we just have to focus on rehabilitation for those patients. Also, it's the fifth leading cause of death. Shockingly, it used to be the third, but I think with how rapid we're getting patients to the hospital and with our intervention windows expanding, we're able to help save some of these patients' lives. And of course, the biggest takeaway is that for every hour that these patients have some sort of occlusion or blood flow block, they're losing 3.5 hours worth of their brain tissue. And that's tissue that we can't get back. Once it's gone, it's gone. So it's just really important to try to get these patients in the hospital as quick as possible. So us doing community education with your team, we're also doing this out in the community. We're at farmers market, we're at Lebanon has a bazaar. We went to Mennonite Village. So we're just trying to really get the education of like, don't take a nap and hopefully the symptoms go away. Just get into the hospital and let the providers figure it out. Types of strokes. Okay, so most of you have probably heard about the different types of strokes, but there's kind of different buckets. So one bucket is you have an ischemic stroke. Ischemic stroke is basically there's something stopping the blood flow in your brain and you're having some sort of ischemic episode where tissue's not getting the nutrients. The other one is a hemorrhagic. Do you guys know what the hemorrhagic strokes are? Yeah, head bleeds. Have you guys ever experienced a hemorrhagic stroke? Hey, good question. I'm glad you clarified that. So I'm curious, what did you guys experience with some of those patients that were having the head bleeds? Yeah. Mm-hmm.
Yeah. Vomiting. Unequal pupils.
Yeah. Yeah.
Coronary respiration.
That sounds like a severe one, definitely. And as you guys probably know, these patients crump quickly, like they can really deteriorate fast. Obviously, our skull is a space where it doesn't expand, so that pressure goes down, and that's when it starts hitting that brainstem. And once you start hitting that brainstem and putting pressure there, that's where it's your heart rate, your respiratory rate, your autonomic system, your livelihood starts being affected. But that's one thing that you really touched on is that strokes. Ischemic strokes typically are not painful. So if you're having someone with a headache, that kind of puts us more like towards the head bleed route. But yeah, you're going to have those extreme headaches, that nausea, vomiting, projectile. These patients are typically miserable. So you have your ischemic strokes, your head bleeds. Which one out of those two do you think has the highest mortality rate? Which one of those patients? Yeah. So they're our lowest population, so we don't see them as much, but they're our highest mortality rate. And then it's kind of a trick question, but do you guys think a TIA is considered a stroke? So
yes, because in one of your categories. Yes.
So very smart. A TIA we do monitor these patients. A definition of a stroke is if we did imaging with a CT or an MRI, we will see brain tissue that has been damaged. With a TIA, the imaging will show nothing. So a TIA, it's kind of where Dr. Sprague's expertise comes into play. It's pretty much a clinical diagnosis. Like you had stroke symptoms, they went away, there was no tissue death. This is basically a warning sign. So a lot of times people do say it's a stroke, which, I mean, it's a stroke category, but it's not actually a stroke diagnosis. So that's really important to know, is that if someone has a TIA, so let's say if you respond to somebody, they started having slurred speech and left-sided weakness, and by the time you got there, it went away. We would still want you to bring those patients into the emergency department. We want to work those patients up, make sure that we're not missing anything, but also go save lives transferring patients. Thanks, guys. So TIAs, if the symptoms go away, we still want them to come in because they might need to be admitted for a further workup. Another thing with TIAs is typically the symptoms go away within 24 hours is kind of another definition, but we don't want to wait 24 hours to see if they go away. So if someone's having the symptoms, we want them to come in. It's a storm. Oh, there it is. Okay, etiology. So basically what can cause strokes. So if you see somebody with AFib, your radar should be a little higher, for stroke symptoms. These patients have a high risk for strokes. You're typically going to see them on some sort of anticoagulant, so Coumadin, Xarelto, Pradaxa, those type of medications, and atherosclerosis, so plaque in the blood vessels. Hypertension is a tricky one because it's very sneaky. Like, people don't know that they have high blood pressure until a lot of times something substantial happens to their body. So high blood pressure, you're at high risk for ischemic stroke, and you're at high risk for a head bleed because just over time it does so much damage to your blood vessels that they just become fragile and just burst. Amyloid angiopathy. Basically, this one is little tiny head bleeds in your brain. We used to have a patient that we had at our stroke support group, and he had this diagnosis, and it was really hard to watch because there's nothing you can really do. It's just over time, you just have tiny little head bleeds. And if you would see his MRI, you would just see these dots all over. And just over time, you just lose your quality of life and just comfort care. And then, people that are doing drugs. I'm going to say, right. The hard part with this population is they're high risk for anything, cardiac, infection. I used to do a lot of ER reviews, case reviews, and there were so many times where, unfortunately, we all become calloused to certain populations and can poo-poo things. But this population is at high risk for a stroke. Identification of ischemic strokes. Basically, with this screen is a lot of times there are different parts of your brains. So if it's happening to your left side, it's going to be happening. You're going to see the symptoms on your right side. So it's the opposite side. Your right hemisphere, you're going to have dysarthria. So you're going to have speech issues. Left-sided sensation changes, left-sided neglect. If you're on your left hemisphere, speech problems, interpretation, and expression. So it's kind of interesting, but your brain is not fully equal on each side. Like, size-wise it is, but there are certain components to your brain so the left side helps you express stuff and receive information, but your right side doesn't have that component. So that's kind of how we're able to delineate maybe where the stroke's coming from. And your brainstem, we've talked about this, but this is where you're going to see that nausea, vomiting, vertigo meaning dizziness, speech or swallowing, abnormal eye movements, and you could find bilateral findings, so both sides could be affected. If the brainstem's involved, it's worrisome. Identifying our head bleeds. Subarachnoid would be the worst headache of their life, light intolerance, stiff neck. Sometimes these patients are the ones that hear like a big clap and then have this worst headache of their life. Our head bleed patients, these are new symptoms for them. It's not like a migraine that they've had before. It's typically like, I've never had this pain before. This is brand new, and they're typically very miserable. So stroke mimics, I'm sure all of you have responded to one of these type of patients. You have alcohol intoxication, slurred speech, and probably not coordinating their bodily functions very well. Brain infections, drug overdose, hypoglycemia, migraines, Bell's. Are you guys familiar with Bell's palsy? Yeah, that's that one-sided facial droop. And seizures and post-seizures. How are you guys familiar with Todd's paralysis? So it was interesting when I was out at one of the other stations, someone had just responded to somebody that had Todd's paralysis. And so what happens is a patient will have a seizure of some sort, it could be new to them, or it could be they've had seizures before, but afterwards they literally can be like completely right-sided, flaccid, or have no movement. They will have stroke-like symptoms, but not be having a stroke. It's something that just eventually, like 2 to 4 hours, will typically just go away. Does that change your care? No. I would never just say, oh, this is probably Todd's paralysis. I would say just get them to the hospital, and we would probably still work these patients up for a stroke, because it's, really, really concerning, and it's not typical.
Yeah, kind of along those lines. Just a couple days ago when I went, I can't remember the three of them brought him in, but this guy came in complete right-sided deficits, facial droop, aphasia, and there was some question about last known well, so not really seemed a candidate plus the benefit today. So candidate. But I started looking through his chart, and he presented the exact same way in 2020. He was sent to Salem, and he had the whole stroke work up there. And what they found was he was in status epilepticus, and he was completely paralyzed. MRI, stone cold normal. So I ended up giving him Ativan pepper on the well.
That's great.
It was, I mean, it just looked like a giant stroke.
Yeah.
He was from, no, he wasn't from the vet school, I don't believe. He had a caregiver that,
So, see, and I wonder, like, is that still the diagnosis of a Todd's paralysis, you think, or it's just a post seizure?
I don't, yeah, I guess, I mean, that I guess wouldn't necessarily fall under. Yeah, I guess I don't know. I don't know if that would technically be called Todd's paralysis.
I don't know if it just is like a neurologist saying like, oh yeah, that's Todd's paralysis to get the diagnosis. I'm not sure, but that's really interesting.
Yeah. It's also interesting if you have a daughter who has complex migraine. So it's a weird family.
Very complex. Yeah. Okay. So, and yes, please, I love share your experiences or whatever. It's nice to hear other people's voices. Are you guys being called out? Okay. So question for you that are not being called out. What do you think is the number one mimic out of all of this group that we typically? Okay. That's not it.
Migraine.
Hypoglycemia. And that's why we typically are the two things that you might experience at the ER is what's their blood sugar and what's their last known well. Like those are our big topics that we're trying to clear up quickly. We have taken patients to imaging and their blood sugar has been 40. So getting that blood sugar before we go and correcting it.
Yeah, people who probably
I know.
Or I because we see a lot of patients, and sometimes I think I heard this before,
Yes.
but it was on another patient.
Yeah.
And then they have stroke symptoms, and they don't think about it for all of them. Oh boy.
Well, I guess their risk for bleeding is very low.
Yeah, but it's not zero.
Right. Yeah, no, it's happened. And so if you correct it and they improve, then you're probably in the clear. But if you correct it and they don't improve, then that's concerning for a stroke. But we do, and I would say we do get a lot of Bell's palsy too. But hypoglycemia is something that you guys can check quickly and help us kind of go through a differential. Okay, so you guys are familiar, obviously, with the Cincinnati. That is your scale. I know that Dr. Sprague is aware that there are different places that are moving to using a BFAST tool. And so that's just a conversation if that's something that you guys will adopt or not. And I guess, if you adopt it or not, I guess our goal today is just to kind of talk to you about the BFAST tool and what we're using. We're definitely robustly getting this education out to the community because this is the tool that we ask them to use as well to help rapidly recognize strokes. But also, this is what we are teaching the triage nurses, the ED nurses to use in the hospital as well. It's kind of like a condensed version of an assessment. So the Cincinnati is your facial droop, your arm weakness or drift, and your speech. And so we're just truthfully adding 2 more assessments to that, that we're hoping that you guys are able to add at some point. So this is basically a bunch of assessments that you can do. A lot of them, are you guys familiar with the term LVO or the acronym LVO or large vessel occlusion? Okay, so a large vessel occlusion is basically a blood clot that goes to the brain. Our CTA can pick it up and we are going to get those patients out. We're going to transfer them out and get a mechanical thrombectomy. So they're going to go up and remove that clot like a Roto-Rooter, not just like go up and grab it. But I think the biggest takeaway from this is just there's not one tool that is going to find our stroke patients 100%. So do the best you can. Sometimes we have to use critical thinking. But a lot of these focus on large vessel occlusions because there's some stations that have, when you're out and about, they have to make decisions of, are we going to a thrombectomy center or are we going to just a hospital that can treat with the medication? So this necessarily isn't focused on where we're at. All of our hospitals in Samaritan, we don't do this procedure. So we have to ship them out no matter what. But so Riverbend, and then some of the Portland hospitals do it, the thrombectomy. Okay, so this is the BFAST tool. I'm really glad we made it really small font for you guys. Sorry. But the 2 components that we're adding are the first 2, and it's the B and E. And what we were finding is that we were missing those strokes that were our posterior strokes. So those are the patients that have balance issues and dizziness. So how many times do you guys respond to dizziness? I know. And now you're just like, seriously, you're going to add this to your stroke? So we do add dizziness and we do treat patients with just dizziness. So I think the big takeaways from this is 1, it has to be a sudden onset. It needs to be a sudden onset, and these symptoms need to be new to the patient. A lot of times, if you're having dizziness, you're going to have another symptom with that in the sense of another stroke-like symptom. Dizziness is not typically by itself. So I guess my biggest takeaway is that if a patient tells you that they're dizzy, trying to help define what dizziness means is really helpful. Like, is this more of an orthostatic dizziness? So if the patient's laying down and then suddenly they're dizzy and almost fall over, that is one, that's more of an orthostatic, possible dehydration type thing. Or is this something where when they're walking, they're kind of like, they can't even walk straight? We had a patient come in just last week, and this poor gentleman was just miserable. He was so dizzy. He was vomiting. He couldn't see straight. And we were doing an assessment on him and he was having nystagmus. So he would look to one side and his eyes would just be ticking. And then he'd look straight and they'd still be ticking. And he pointed at me and he's like, I don't know, but you're just jerking up and down as I look at you. So we were having a really hard time figuring out what was going on with this gentleman. We were really concerned for a stroke. And we had him sit at the edge of the bed because this is another way that you can kind of watch for a stroke symptom is if they can't walk, have them sit at the edge of the bed, have them put their arms across their chest and see how they can control their trunk. See if if they start falling to one side, which this gentleman did, that's concerning. So that's another way that you guys can kind of help in the ER is like when the patient gets up to walk to the gurney, how do they walk? That's a good communication tool. I'm not wanting you guys to add, I'm just wanting you to maybe be more observant. Or when you're assessing a patient, kind of just what is dizziness is a big, is helpful to know what their definition is. And then eyes, so vision changes, double vision, blurred vision. Is there some peripheral blindness that happens? One thing that I do frequently is when I'm assessing a patient and let's say Mark's my patient, I'll talk to him here. And then a lot of times I'll just move to the opposite side because there I can see he's tracking me both sides. And also he's noticing that there's a left and a right. So he's able to notice that I'm over on his opposite side. So we're looking for neglect. Sometimes people will stop midline because they're neglectful of that whole left side. So that's just a quick tool for vision. Face. So these are the ones that you guys are familiar with. Facial droop, arm. So if your arm's involved, your legs probably involved as well. How many patients have you gone on where they got up out of bed and they fall and collapse because they've lost the whole right side to their body? Speech. So slurred speech, mute, incomprehensible, doesn't make sense to the conversation. Those are all concerning. And then terrible headache. So this is a little addition and it's more for our education with you. And the takeaway is that if someone's having the worst headache of their life, we want them to come in code 3 stroke alert. These patients are still a stroke patient that we want to really try to treat quickly. We recognized at Corvallis with a few of our patients that we noticed that the possible extreme headaches, vomiting patients were not being treated stroke-like patients. And so the reason that we really wanted to highlight the terrible headache is because we did have a patient sitting on the gurney with EMS probably for about a half hour with this excruciating headache, vomiting. They couldn't really control any of the symptoms. And in the end, he was having a head bleed. So just to kind of keep that in mind. And then T is for time. My little soapbox, but if you can, it is so helpful if you guys can give us an actual time that the patient's symptoms started. It becomes a little complicated when the patient's brought in and they're like, yes, this happened a half hour ago. Okay, half hour when you picked them up, half hour when you got there, half hour when they called 911. So just kind of trying to pinpoint that because this could be the difference if we can treat them with the medication or not. So that's really, really helpful. If you guys can't, we get it. A lot of times when patients come in, I'll be calling the nursing facility, I'll be calling family. So it's really helpful to get that time and also to have family come in with the patient. I'm a huge advocate for patients that are having, cardiac arrest, trauma, or stroke, that they have at least one person in the room with them because the likelihood of them having some major disability that they can't make decisions is very high. So we want those patients in there quickly because they're the best historian for those patients.
In terms of the time, last known moment, there's big disruptions. The first notice isn't always the most.
Very good point. And I think like that comes to the point where it's, we'll get patients that come in and go, yeah, I woke up and I just was all of a sudden dizzy and they were having a hard time with their, getting their words out. And so people that wake up, we can't take that time. So then what's the next step is, well, when did they go to bed? So when they went to bed, okay, when you went to bed, did you have those problems? Did you have those symptoms? How did you feel? And if they're like, no, I was totally fine, went to bed, and then I woke up like this. we take that time that they went to bed as their last known well.
Or if they got it from. bathroom.
Right.
And if it's an older person, they usually go quite often.
Yeah, no, that's a good example. But if the patient does say, I woke up, I was having breakfast, totally fine, and then suddenly these symptoms came on, then that would be your last known well. Balance problems would be concerning. But like, I think my biggest takeaway is try to see if there's other symptoms, because a lot of times there's going to be other symptoms except just dizziness. But if you're suspicious, I would do the stroke alert and then bring them to the hospital. When you do a stroke alert, it's not like a code 99. You're not going to have 50 people showing up. The goal is to get the provider there, and then you guys can have that discussion. You know, the blood sugar's fine, this dizziness, kind of, you know, the provider is going to be the expert to help move that along. If they want to keep going with the stroke alert, perfect. If not, they can take them to a room and do a different exam. So I would say, yeah, if you're suspicious, especially with gait issues, dizziness, it's hard. It's hard. I mean, but if you get to someone who's dizzy and their heart rate's 180 and blood pressure's low, that might be that's where that critical thinking comes in a little bit, but it's not black and white, unfortunately. Yes, exactly.
But stroke is one of them, and it's always, you know, always what we're trying to get all the other things. And so, you know, the big things with the dizziness is, you know, is it constant? You know, is it positional? Is it, you know, if they hold position, does it go away completely and they roll over to the side? If it's dizzy, you know, and it goes away again once they hold position. Do they have other symptoms with it? Is it a completely new thing? Do they have a headache with it?
Mm-hmm.
You know, those are kind of things.
That's helpful. Yeah. Okay, so I know I was talking with Mark earlier, and you guys are aware that we're calling stroke alerts for last known well less than 24 hours. And he goes, it'd be nice, like, you know, to get more information on that. So one of the big reasons we're doing that. So we treat people with a thrombectomy up to 24 hours. So the 0 to 4.5 hours, you could get the thrombolytic, which is tenecteplase. So that's our blood clot, our medication that we use to try to, yes, eat the clot. Thank you. Thanks.
That's how I describe it.
Yes. So they can get the tenecteplase and they could get a thrombectomy. So that mechanical removal of the blood clot. After that 4.5 hour window, it's only a thrombectomy candidate. So they can't get the medication, but they could possibly be transferred for a clot removal. So that is why we've expanded the window, is because we found with a lot of our patients at Good Sam in Albany that these patients were not being expedited as much. They're kind of like, oh, we have a little bit more time. It's not that big of a deal. And also having that conversation with neurology, hey, this might be a thrombectomy candidate. So we have expanded that window. We do expect code stroke alerts to increase in numbers. And we've even talked to Providence, because we work closely with Providence and we communicate with OHSU as well. They also have that window. They've had it for years. So we're kind of behind times, but it definitely is a window that we're using. And when we talk to Providence, so I don't know if you guys knew this, but we have a contract with Providence where if we have a patient that comes into any Samaritan hospital, we're concerned for a stroke, they have a teleneurologist, because with Samaritan, we don't have any neurology. And so in order to help support our community, we have stroke neurologists that will beam in. It's literally like a screen on a robot type thing. And the neurologist will beam in and assess the patient and talk to them. So we do have that relationship. And when we talked to them, we're like, well, we're going to be calling you more. They're like, that's fine, bring it on. So they're aware that we have upped our last known well criteria to 24 hours. How have you guys noticed more stroke alerts or since then, or have you had to?
Yeah, I haven't noticed that.
Okay.
But we started doing that. Like, so, yeah. So it seems to be positive.
Good.
I mean, unfortunately, the vast majority of the stroke patients don't fall in that 3-4 hour window. So
That's what's hard,
that's what
is people are,
I couldn't move my right side, so I went and
I know.
woke up and I still couldn't move my right side. So I decided to call me.
Yeah, exactly. You're like, "Dang it." Yeah, and that's why we're trying to get out in the community. Kind of trying to do that education. Okay, so this is one of the main reasons why we're doing what we're doing is I love the whole term, but we like to save the penumbra. The penumbra is what we're trying to give blood flow to. So the little black dot that you see up there, that's the tissue that's been damaged already. So that's the stroke. And what we're trying to save is all the real estate around that. So that is what we call the penumbra, and that is what we're trying to get blood flow to, because that is the area where the stroke is affecting. It hasn't damaged that tissue yet, but it could. And so you can see that the quicker we move, the better chances they have for less disability. And also with our thrombectomy candidates, it's pretty interesting. So they have an imaging program up in Portland where they can see the difference. So they can see if doing a thrombectomy is worth it or not. So they'll look and see if the stroke is this big and they have a big penumbra, the likelihood of them treating that patient is very high. But if the stroke is this big, this big and the penumbra is not much bigger than that, they're not going to do the thrombectomy on that patient. So the thrombolysis is, we chose tenecteplase because it has a higher likelihood of treating our large vessel occlusions. The nurses love it because it's a bolus. I don't know if you guys had to transfer our alteplase patients, but sometimes the drip would still be going because it took an hour for it to be infused. And then the thrombectomy needs to be within the 24 hours, and it is an emergent transfer. If we have to transfer these patients, typically our first line of transportation is life flight, depending on the location, but they are a code 3 transfer. That's a good question. So as that blood flow stops to that blood vessel tissue, it becomes friable, so it becomes fragile. So the longer that it hasn't had that blood flow, the more fragile it gets. And so if you have a blood clot, and let's say it's been there for 5 or 6 hours, and we give you the medication and we open up that blood flow, that pressure, the likelihood of you having a head bleed's high. So 0 to 3 hour window, I learned this from one of our case reviews with Providence. 0 to 3 hour window is the golden time that neurologists like to treat. Like that's their happy comfort zone. The 3 to 4.5 hour window, it's still possible, but they start looking at how old you are. If you're greater than, if you're older than 85, they also start looking at comorbidities, quality of life. They don't like to really treat within that window, but they will if it's the right candidate.
You look at the graph where head bleeds at about 3 hours or so. Right. Well, yeah. I mean, like you're saying, so those areas of ischemia, that area that has had no oxygen from the clot has died, and basically it's formed a clot to prevent a bleed. I mean, the brain doesn't want to bleed into itself, so as soon as there's disruption of blood vessels, it's going to form a clot there. So that clot is already there, and those blood vessels are essentially open to the brain. And so you throw in, tenecteplase in there, you dissolve that clot, all of a sudden, like, blood vessels open up. And so, if you can get it before those tissues start breaking down, then that, that before the 3 hour mark, then. Thrombectomy is also removing the clot. There's a risk of bleeding from that as well. But that clot isn't necessarily in the brain itself, right? It's in what the blood vessels go through, right? So the tissue of the brain is affected, but that's that number. You get this positive number, whereas the brain is deprived of oxygen, but it's in the process of dying, but it's not dead. And so if you can get that clot, you can get that oxygen back in there, and that, those cells.
And that window up to 24 hours, they would, if it's beyond the thrombal, so if it's beyond the medication window and they do the thrombectomy, they can remove the blood clot, but they're not going to have, if they do have a little hemorrhage, they have a clotting factor. So we haven't interrupted that. And so their likelihood of bleeding is very low because they don't have that medication that interrupts your clotting factors. No,
So that's all.
that's all Portland or Eugene. Yeah. And that's another thing, is that we do have a contract with Providence to do our acute neurology. We don't have a contract with them to do our thrombectomies. So there's been discussions around, well, why do we always go to Portland? Why do we always go to Providence? And a lot of times it's a fluid transfer. Hopefully it's not always, but it's more of a fluid transfer because they've already seen the patient. They have the images. We have them on the phone and we can do that phone call. We used to have a provider in Albany that was like, I don't want to use Providence, Riverbend's closer. And he did that a couple of times and he was like, that was the most clustery transfer I've ever done. I'll just continue with Providence. So I think it's just more of a fluid transfer, but if we have to transfer to Riverbend, we can do that. So it's not a set in stone thing, or OHSU or Legacy. But we have ran numbers on, how many patients do we transfer out with the system? Because, if Good Sam could do the thrombectomy for the system, but we still don't have the supportive numbers. You need like 30 a year. And I would say just between Albany and Good Sam, we've had 10. So just don't have those numbers.
You gotta remember that not everybody that we send up our thrombectomy will get the
Yeah.
thrombectomy, depending on what that interventionalists. So a significant portion of them will actually end up going there and get evaluated.
So I don't know if have you heard that we've been talking about CT perfusion? Yeah,
We've
Good
been
Sam.
talking about that for a while. I've been talking to our administration about getting that, because that would be extremely helpful before we transfer somebody over. Because a lot of times families are, especially in this area, it's a hardship to send them up to Portland. and have families go up there.
100%. Yeah.
So it's, I've been asking about that for a while, but they're talking about actually implementing that now.
Mm-hmm. Yeah. So, and I think we're going to start with Good Sam in Albany, and then see how that goes and see if it's worth it, because even our neuroradiologist is kind of like, oh, it's nice. He wasn't too excited about it, but I think that if we had at least 2 or 3 patients that we could have kept, that it would have been a bit beneficial to get that CT perfusion because they had some pretty detrimental things happen to them. But we're thinking of getting that perfusion scan because our hopes are to keep them in the community and not transfer them just because, this could be a life flight transfer and then they don't have anything done.
Yeah.
Like, that's pretty big. Okay, so people that can't get it, the thrombolysis, the tenecteplase, basically if you've had any sort of internal bleeding, you're a high risk for, having, you're bleeding after tenecteplase. One thing I do want to really hone in on is anticoagulants. Okay, so if you have a patient that is in AFib and they are on an anticoagulant, that does not take them out of the window to get the treatment. So either I wouldn't, if someone's on Coumadin or Xarelto, I would still call a stroke alert. Bring them to the ER. So if the patients had Coumadin, if they're taking Coumadin and they're below the INR of 1.7, they can still have tenecteplase. If they've taken Xarelto, Pradaxa, Eliquis, kind of the newer anticoagulants, and they didn't take it for the last 2 days, they could still get the thrombolytic. So I think the biggest thing is if somebody said, "Oh, I haven't taken my I haven't taken my Coumadin for a couple days," ding ding, that's concerning because they might not be, their blood might not be that thin, so they could be showering clots, so their stroke risk is higher. I get patients pretty frequent that come in and they're like, "Yeah, I'm going for a dental procedure, so my doctor told me to stop my Xarelto. So I've stopped it. It's been a couple days." Well, unfortunately, they had a stroke because they were off that medication. So we still treated them. I did have a guy in Albany come in, and he came in with left-sided weakness and expressive aphasia. So he wasn't able to get his words out. And he was like, "Yeah, same thing. I was going for a procedure, stopped my Xarelto." And the wife was like, "I was so concerned that he was having a stroke. I told him to take his Xarelto before he came in." Yeah, I know. So then since he took it that day, he can't get the blood thinner. So that's another reason we want to do education. One thing that we tell patients is do not take anything. Don't take aspirin, don't take your anticoagulants, don't take anything to drink before you come in because they're at high risk for aspiration. Especially if their speech is involved, their likelihood of them being able to swallow safely is, a little altered. So definitely don't want these patients taking anything. I've even had families say, "Oh," or no, I was doing a community education and someone was like, "Yeah, I heard that you're supposed to," I don't remember what it was, but she goes, "I think it was Hennessy. You're supposed to take a shot of Hennessy before you come in." And I'm like, no. I mean, that might be helpful to calm you down, but if that's in your policy, Yeah, so the liter of Hennessy that's in the ambulance, you need to take it out. Oh, that was pretty entertaining. Good question. So I call the big dogs medications are like warfarin and the ones I've talked about, Xarelto and Eliquis. The little dogs, which we call antiplatelets, are like aspirin, Plavix. Those ones do not take somebody out of getting the medication, but the big ones do, or can, I should say. Okay, so with our hemorrhagic strokes, I think the biggest takeaway is there's not a whole lot we can do for them other than reversing why they're bleeding and expanding their brain, their skull, if needed. So there are interventions called like clamping. So if there's some sort of aneurysm or some sort of blood vessel that's bleeding, they can do a clamping or a coiling. So sometimes there's the blood vessel and then it bulges out for some sort of aneurysm, and they put a coil in there that occludes all that, or craniectomy, so removal of the skull to help it expand, or not help expand, but let it expand. But I would say for the most part, Good Sam is the only one that has neurosurgery, so these head bleeds are transferred to us, and we do some of these, except we don't do the clamping, coiling. All of that is transferred out as well. Oh. Mm. Would you guys be doing that? Oh,
So, yeah, I'm not looking forward to ever using it. but it came from a case, we had a kid who had an epidural. And, there was some delay. The life flight was flying, or something was a delay, and it was we didn't have it. We ended up granted it. So this would have been a situation where if the kid started here.
Would he have been a case where you probably would have?
Potentially, yeah.
Yeah.
I mean, I think we would spoke with the neurosurgeon on the other end, say, yeah, this kid looks bad. There's gonna be, we're not gonna be able to get him up there for a couple hours. I love the holds.
Put them on the Sava or play or take out a board of it, or you do it?
No, we just, it's basically like an auger. You put it on there and you go through, and it's got a special bit, so it will feed through, but once it gets to the skull, it kind of retracts, so you don't feel that.
Oh, that kid, like, that's nauseating.
No,
Help that bleed a little bit more.
it's not pretty big.
So is that considered a burr hole?
Yeah, it's sort of like
Okay.
Yeah, I don't know. That's at that point, it's out of my hand.
Flip up the hair.
Oh, and then I think the last thing I just want to take away is, a lot of times when you guys get to the ED, the workflow tends to be just take them straight to imaging. And the purpose for that is for us to get that CT. So we're going to do 2 images right away. We're going to do a CT, which does not have contrast, and we're going to do a CTA. So the CT is going to show us, do they have a head bleed or not? And if they do not have a head bleed, they can probably get the the tenecteplase. The next one is the CTA, and that basically is just like the plumbing in your brain. Like, is there a big occlusion? Is there that LVO that we talked about, the large vessel occlusion? So if that's negative, so CT is negative for a head bleed, CTA is negative for a large vessel occlusion, we still could treat these patients, because if our suspicion for stroke is high, we would still treat that patient, because they could be having little strokes deeper in the brain that we didn't pick up right away. Honestly, like, the only way to actually know if someone's had a stroke is an MRI. And we typically don't do MRIs. They're not as quick to get. And scheduling of MRI techs. And so CTA is just the quickest way to get these images done. If patient CTA does come back and they have a large vessel occlusion and they're within the 0 to 4.5 hour window, they could get the medication and be transferred out. So we do, and Dr. Sprague, I don't know if you guys do quick MRIs very often, but well, I should say quicker. A limited, not as many.
So the MRI machine is monitored. Essentially, it's now big. So if they're on any type of monitor.
Right.
So yeah, so if somebody falls outside of the thrombolysis time frame, or is excluded for whatever reason, CT is negative, CTA is negative, so it's now large vessel occlusion. Sometimes if it's during banker's hours and they're otherwise stable, sometimes it goes away.
Right. Well, in that so for example, we had that patient last week that was that dizzy patient that was just miserable, and the thought of, like, he was in the window, he came within the first hour, and we did the CT, CTA, they were all negative, and the neurologist was really concerned that this was not a stroke, but we didn't want to not treat. So we did end up going for a what we call limited MRI. And when we went for that, it showed that he was not having a stroke. So we did not treat with a thrombolytic. So the patients that we use that quick MRI, well, I should say quicker MRI on, are kind of those patients that are within the window of being treated and are suspicion, we're really confused if they're having a stroke or not. And a lot of times it's a lot on younger patients that this is happening. So it's, in the end, strokes are confusing, unfortunately. And it's funny because Dr. Sprague, you and Dr. Gowing have also expressed how like dizzy patients, and they're just strokes. Strokes aren't the most exciting patients to take on because they can be complicated. It's a great note to end on, right?
That dizzy. Hopefully that's somebody else will sign up for it.
Yeah. All right. Do any of you have any questions? No?
Are they calling in the DFAT or when they're given their stroke alert? How many 4 hours?
That's my understanding, is it's part of their policy and they're doing the beat fast.
Maybe there's a lot more activations for just dizziness then with the feedback?
I couldn't answer that. I don't know. We haven't categorized that part. We haven't categorized like what they're calling the stroke alerts. But we have doubled in our stroke alerts since we've done the last known well less than 24 hours. It was about the same time. Yeah.
I can see the 24 hours. Have an increase in the number. But I can also see around here with all of the nursing homes. Like every other patient from there is busy.
50% of the people we bring in.
Yeah.
I know. I know.
One thing or another.
So for you guys, if you're at a scene and, you know, the patient's complaining of dizziness, if it's not their primary complaint, they're complaining, feel weak, tired, fever, it's not the primary one.
Mm-hmm.
You can use a little bit of clinical judgment. If their primary complaint is dizziness, this is something they have that. If you have a question about it, you can always call it. That's and most of the time I would do as possible. Because there's some physical things that may differentiate if the patient's cooperative enough, but yeah, I mean, if they say, oh yeah, I get this like once every couple of years, similar to my prior episode, they have no other symptoms, the vital signs are stable, the EKG looks okay. Again, that's clinical judgment. Most likely it's not going to be stroke, right? Could it be still stroke? Sure, absolutely. That's dizziness. But if it's consistent with something they've had in the past,
I do agree with that one too. Yeah, like because we do get patients and they're like, no, I've had this a couple years ago or last year, and typically we'll kind of do a hands down or hands off. And we have started canceling code strokes too. So in the past we haven't overhead canceled, and but now with maybe that's part of it, is the be fast, having that dizziness or that last known well less than 24 hours has kind of grade things a little bit. And so when the provider responds, and shocking, the patient gives the providers more information, they find out stuff, a little bit easier than us sometimes. They'll, call off a code stroke, which I think is very smart because it lets pharmacy know we're done. Imaging, we're not coming in hot. It's a really awesome communication tool. And I'm happy to hear when they're canceled because that means that we're overcalling. We don't want to be undercalling. If all of our code strokes are 100% strokes, we're missing patients. So we expect the overcalling. We responded to a code stroke the other day where the patient came in, and when the provider got out there, they found his blood pressure to be in the 70s. And so our provider's like, yeah, he is having some cerebral perfusion issues, but not a stroke. Mm-hmm. So we canceled the code stroke. So, overcall, play it safe. But
this doesn't change our training.
Right, yeah, I would still bring him to us. I mean, there's some systems that they use scoring tools to try to identify those who most likely have a large vessel occlusion and then, divert those to someplace that has thrombectomy capabilities, right? Or, closest place here would be Riverbend. But we haven't really included that into it. It's just typically just come to us.
Yeah, so all 5 sites, we are able to give the Tenecteplase. So we really don't want we don't want you guys blowing by a hospital. Just go to your nearest hospital so they can be treated. That is one thing that we do review is like if a patient came from, let's say, Lebanon and ended up going to Corvallis for stroke alert. We would look into that and just see why. And a lot of times there's a very valid reason. We had one that should have gone to should have gone to Albany. But Albany, they didn't know Albany was on divert, so they went to Corvallis. So it's just a lot of times there's a very valid reason, but we do look at those because our goal is not to bypass any hospital.
Really, you shouldn't be bypassed, even if the hospitals has a functioning CT scan.
Yes.
ER provider. Regardless of the diversion status of our
Your nurse.
Yeah, I mean, the protocol and the nationally recognized standard goes from the hospital. So if you call it in and they say our CT scanner is not working, we can't give them, and we can't do anything for them because we can't give them Tenecteplase without scanning their head. Because if they have a bleed, we just use that. So, so if we don't have a CT scanner, you'll have to bypass us. I really try to limit the hard but even in that situation, if it's an emergent, if it's stroke, unstable trauma, they still come. Yeah, I'm not.
That's a really good question. I don't know that answer. I can find out.
I mean,
They should be able to. Okay, I can find that out.
At the other end, we're close to
Mhm. So are there a lot of times that you're going, not a lot, are there times that you're going to certain facilities or houses and you have to choose between Lebanon and Riverbend?
Brownsville. Brownsville, down way off the gap.
Okay. Okay.
Yeah.
Yeah.
Riverbend. Feel real south. Riverbend closer. Yeah.
Okay. So, and Dr. Sprague, that would be like maybe a conversation, but like if giving them a tool for a large vessel occlusion assessment, if they're having to go between Riverbend and Lebanon.
Yeah, I mean, I think right now it's good one.
Closest. Okay.
I mean,
I mean, if it looks like a big stroke, I would head to Riverbend.
yeah, I mean,
If
you're
they have
kind
that
of on
choice.
that borderline, and
Yeah.
the person's like fully paralyzed and they
Yeah.
gaze deviation and they're not talking, I'm okay with it.
Yeah. Yeah. I agree. Yeah. Okay. Well, I don't have anything else.
Thank you.
Yeah. Thank you for having me.